Good evening, friends. Uh, on behalf of World Dental Association, myself, Dr. Swapnil Badjate, I'd like to welcome you all for another excellent session on our group World Dental Association. Uh, the journey these past few months has been very, very stressful for one and all. So these lockdown times, World Dental Association has tried and touched every aspects of dentistry which were possible amongst us. And thank you to all our viewers and members who've been giving us tremendous response. And the response for this recently held Endo Masterclass was just amazing, and that has kept us motivated to arrange many more such programs in future. Coming to today's session, it's a little different session. Probably lesser people touch these topics and dare to talk on this. And today we have two masters of this topic, the orofacial pain. Many people don't even think that this is a dentist's perspective, but it is all about a dentist's perspective regarding clinical considerations of orofacial pain of dental and non-dental origin. So I am damn sure this will be a very, very exciting session, and I hope you all enjoy this session today. We have two very esteemed speakers amongst us today, Dr. Davis Thomas sir and Dr. Kartik Raman sir. Now I'd like to request my colleague, Dr. Saurabh Shah, to please introduce the speakers today. Over to you, Saurabh sir.
Yes, Dr. Swapnil. Thank you very much. Today we really have an interesting topic on orofacial pain. Being a clinical dentist for myself for past 12 years, seeing teeth, we feel we have become our treatment obliged only towards teeth, fillings, crowns, and root canals. But in actuality, we are much more obliged towards our patients to get a source of their pain and move away from teeth towards musculature, joints. So for on this topic, I welcome Dr. Davis Thomas. Uh, Dr. Davis Thomas, welcome, sir. Sir, you're on mute,
Yes.
sir.
Yes. Good
sir.
evening, folks.
So,
Thank you. Thank you.
good evening, sir. Good evening. Davis, a short introduction about Dr. Davis Thomas. Dr. Davis Thomas is a pioneer and world leader in orofacial pain. Sir has so many degrees, starting right from 1992, from Bachelor's of Dental Surgery from Manipal to DDS from New York University to advanced education in general dentistry from New York University, mini residency in TMD and orofacial pain, postgraduate fellowship and TMD and orofacial pain from of dentistry at New Jersey, masters in TMD and orofacial pain, masters in sleep apnea from University of Sydney, Australia, and masters in clinical pain management from University of Edinburgh, UK. So, sir has covered almost US, UK, and Australia, all three continents, and getting an experience and clinical experience. So, sir is a sought out expert, a leading expert in this orofacial pain and TMD. And I'll also welcome Dr. Kartik Raman. Welcome, Dr. Kartik.
Thank you. Thank you so much.
So, Dr. Kartik Raman is also is a postgraduate endodontics and a professor at CSMSS Dental College, and is currently undergoing fellowship in orofacial pain and sleep apnea under Dr. Davis Thomas. And his main areas of practice are conservative dentistry, endodontics, orofacial pain, TMD, dental sleep apnea, and soft tissue laser. So we have a good, very pioneers in the field of orofacial pain. Without wasting much time, I'll request Dr. Davis Thomas to take the stage, and I'll share sir's presentation.
Let me go to full screen if I can. Hold on for a moment. Can you guys see the full screen from me? Yeah. Okay. Great. Okay. Thank you, Dr. Saurabh Shah and Dr. Swapnil Bajade, and thank you for the organizers for giving me an opportunity to present for you as well. And my student, an astute clinician, he is also here, Kartik Raman. So thank you, Kartik, for really organizing this. And I know you've been persistent and very persuasive in bringing orofacial pain to the field in India, in addition to
Yes.
what you're doing at your own practice. So thank you for that.
Yes. Thank you,
Um,
sir.
Two things I noticed is one, I think it was either Swapnil who talked about initially, was that the teeth that you get stuck with, and yes, that is what many, sometimes most dentists feel as well, that you have a case after case after case for teeth to be corrected, which is a great thing. I love doing it. I'm first a general dentist and then an orofacial pain. There is no way you can learn orofacial pain without knowing dentistry to its fullest. So my first message to all my students and even colleagues and budding dentists is you learn dentistry first, all the principles of it very clearly before you get into orofacial pain. It's only a continuum. It's not instead of dentistry. And I love doing general dentistry and reconstructive dentistry. The second thing I noticed is that in COVID days, we are really going through something entirely different from what any of us can remember. I don't think if you are like 80 years old, 90 years old, I don't think you can remember anything like this in your lifetime. So we're going through unprecedented times, and we just need to adapt to this. That's all we can do at this point. Vaccines and everything might come, but we cannot lose our spirit um, and have go down with this. This is going to continue, and meanwhile, life is going to go ahead as well. So I hope that all the dentists who are listening or other professionals too have joined. Quite a few of my students have joined. I welcome all to the program. I thank the organizers, and I'm starting with orofacial pain. We're going to have approximately an hour and a half. So I have a small job to do, which is in an hour and a half approximately, I'm going to condense and with Karthik what I've learned in the last 15 years. So if you do the ratio, 15 years to 1.5 hours, that is not easy. So what we will do is just a micro section of what this vast field of the new specialty of orofacial pain is. That's all we can do today at this point, but that is enough for, I think, to incite some interest and scintillate your thoughts. Every lecture I put this on, every presentation, this is one of my favorite things is Tamasoma Jyotirgamaya. I think all of you know this already. The darkness of ignorance, we have to get rid of it. You don't have to struggle. You just bring some light of knowledge into it passively. And I'm repeating that passively, that darkness of ignorance will go away. Today, many of you will be novices listening to this. Some of you have heard of it. Some of you have some other philosophies. I'm not going to ask or request that you throw out anything you learned. Just keep that in a separate box and open up a new little box in your brain and see if this fits into your philosophy. And maybe it will, and I hope it does. And that is my prayer today as I start this short introduction to orofacial pain. That's where we live. This is what we are looking at in a couple of months. I have a feeling this is where we're going. It's very beautiful, but cold does bring some pains. So we'll talk about it at another occasion if we get a chance to. That is my email, and I have a business website. A lot of links are given at shoretmj.com. You can visit it. It will be updated again in the next couple of months. I've been busy with this COVID things and patient schedules and stuff like that, but we'll update it. I'm not going to bore you with a definition of pain, but let's understand that International Association for the Study of Pain, IASP, those are the authorities in pain in the world for around, let's say, 190, 200 countries, and that includes India too. They define pain. And the second definition I really want to remember is that pain is what the patient says it hurts. If they say it hurts, it doesn't matter if you're tickling the patient. He says or she says, "Doc, that hurts." It is the definition of pain. So let's stop defining pain for patients. Let's say, I agree, this is what it is. It hurts you, I'll stop. This was the special commentary at the ADA, JADA, Journal of American Dental Association, um, 2 months back. And it says, it introduces the 12th specialty of dentistry, which is orofacial pain. Incidentally, last week, Qatar, the country of Qatar, it approved orofacial pain as a specialty. I just got that information. It is going to spread, and it's going to spread like fire across the Middle East as well. They've been reluctant, and in India too. I hope that your dental association and the dental councils and whoever's related to this accept and recognize this as a specialty, not just for having a specialty status, but for the betterment of patients, basically, and our profession. Because all these weird concepts that we've been spread around that does not make sense scientifically, those concepts have to be questioned. And I don't mind any in the audience questioning any principle I'm saying, not during the short one, but we will have a time to reply and respond and discuss. Like my favorite text, Bhagavatam, it says it should be a samvada, a mutual conversation, not in my hands and I'm giving it to you like a blessing. It should be a conversation, samvada. So this should I hope and pray that this short one will begin as a samvada, as a conversation. So we know so many pain paradigms we have seen. Everyone knows pain referral from muscle to tooth. If you don't know, please learn about this. This is one of the biggest mistakes in dentistry that happen, medical mistakes. And when you know it and you continue, then it becomes probably malpractice. So tooth pain referred from a muscle. Tooth pain referred from sinus. We learned it in dental school. Tooth pain can refer from the upper jaw to the lower jaw. So for some people, it's questionable. I'm telling you, literature-wise, it's absolutely clear as water. Pain referral from left to right. This was questioned long time back. We know this happens. And if you need to, please look up a term called mirror image pain. Mirror image pain. You'll be surprised what you find in the literature. And then you have orofacial pain affecting apparent remote organs such as hand. People, when I lecture, sometimes they say, what the heck is he talking about? Well, it is true, because then you go into the deepest knowledge that you need to have in neuroscience. And then you will find there's something called homunculus, which is how the body is represented in pain in the brain. If you understand that, this is not such a weird thing to understand. But for now, believe me when I say it, orofacial pain could eventually affect apparently remote organs such as the hand or other organs. So what is the scope of this 12th specialty, the new specialty of dentistry, orofacial pain? TMJ, TMD, musculoskeletal. We see the garden variety a lot. Neuropathic, trigeminal neuralgia, neuropathies. And there's a new term, a newer term, painful post-traumatic trigeminal neuropathy. The people ask, what the heck is this thing? Well, anything we do in terms of cutting a tooth, injecting, reflecting a flap, extracting, pulpotomy, pulpectomy, any of the deep scaling, any of these procedures can, in the right person, end up in painful post-traumatic trigeminal neuropathy. Big term, small concept. Some type of nerve damage, which then leads to bizarre types of pain. Bizarre for the untrained dentist, not for the trained dentist. And that is why we intend to train both in India and other countries. Neurovascular pain. In the Mumbai batch where Kartik started his 150 hours with me and my fellows, one of the first cases in the first batch of class of students was a poor little 24-year-old lady that was scheduled just for a consult. And 2 days later, she's scheduled for a root canal on a tooth that absolutely has no cavity. So please take away the term intentional root canal from our vocabulary. I would say that is stupidity root canal. This patient was scheduled almost on the brink of divorce from a 1.5 year marriage because her pain cannot be diagnosed. For me, it was relatively simple, but that's 15 years in my credit and behind me. So, but I say every single case humbles you down. It's not like ego. And this poor lady, um, 24 or 25 max, she was scheduled for root canal after like 5 visits of bonding and this and trimming down and grinding teeth and attaching her head to things. It was horrible. But we know that it was a migraine called mid-face migraine or facial migraine that presents as pain similar to tooth pulp pain on teeth. So these dentists are now, without the lack of knowledge, scheduling bondings and trimming teeth and fillings and root canals, intentional root canals on these otherwise virgin teeth. When do we stop? So I urge people to learn the science. Trigeminal autonomic cephalgias. This is a headache that could appear on the teeth, and you cannot imagine. You can only imagine probably how much medical mistakes will happen if a case like this comes to a dentist or even any specialty of dentistry that is right now existing except orofacial pain. Non-odontogenic toothaches. I mean, this is misery after misery after misery for the patient, the family, and the dentists that are treating these cases. And please remember, none of these cases get the answer from attaching the patient's head to a scanner or some type of wires. Your wiring should be inside the brain that the clinician has, not attaching to some type of machine. So non-odontogenic toothaches, you have a scientific way that you can really delineate these cases. These are not easy, but you change one life, that is still worth it. Snoring and sleep apnea now crept up big time in the last 20 years to 25 years. We'll talk a little bit about that. Sleep and pain and sleep and orificial pain, my favorite topic, and I publish in this. Systemic factors in orificial pain. If you don't know systemic factors, there is no way, I guarantee you, you can use whatever appliance you want to use on the patient's head, tongue, neck, rest of the body. I know that there is a quack somewhere out of Virginia. I won't mention names, east coast of USA, that used to say that you put an appliance in the patient's mouth, the patient miraculously walks out from disabled a chair. And I've seen the videos. Can you imagine the nonsense that is associated with it? Because they have not read the neuroscience that is behind it. It's not the appliance. You can give them something to bite on, it might change their habit too. So those are quackeries. That I'm talking about is actual literature, evidence, and science supported principles of orificial pain. And there are so many others that come under orificial pain as well. Then you have research and clinical. And most importantly, I said this again, evidence, science, literature, and the truth. Not tooth and nothing but the truth and nothing but the truth. Let that be our logo. Let that be our motto. TMJ is a small component of what I do, TMJ, TMD. The last thing I care about is this disc that just comes in and out, anterior disc displacement with reduction, without reduction, clicking. We really do not have any successful treatment, literature and evidence based, for just anterior disc displacement, just a click. And trying to do a surgical procedure is the last thing I want my patients to go through, not under my care, for this type of disc displacement with reduction. At the clicks. Clicks are not to be treated unless there is a click with pain. Then you do the workup for pain, not the click. Click we already know. And does it really matter if it's a mesial displacement, distal displacement, anterior or posterior? Really not much. And this is science. But you can have pseudoscience saying, oh, we should treat this, otherwise it goes to osteoarthritis. It is a bunch of nonsense, and let's get out of this nonsense and look at evidence. Ask them to show evidence in the literature, in science, that says this, that the disc displacement can then lead to significant osteoarthritis of the jaw. TMJ disorders. We have so many classifications. RDC, research diagnostic criteria, temporomandibular joint disorder. Then they came up with DC-TMD. I'm not happy with either one of them. Then somebody said muscular and skeletal. Okay. Congenital developmental, there's another class. My just minimal classification for all of us, and we have citations for all these, by the way, is just look at it as, for a clinician, those of you listening, inflammatory, mechanical, neuropathic, or combination of all this. Um, I've been practicing this for some time, and I can tell you that it will help you. Simple classifications. If you do want to do research, then please go ahead and look at the RDC-TMD and DC-TMD criteria. Arthritis. This is taken directly from articles that talk about arthritis itself. And out of these, the most important one that you will see usually is osteoarthritis and degenerative or osteo. What do you do about it? Well, pretty much palliative, and the joint adapts. There is the faculty that say that this should be aggressively treated either have not read the literature or don't know the facts of how many percentage of people in the world have arthritis, osteoarthritis. There is so many other types of arthritis can affect. If you do not know systemic and you're attaching the head of this patient and neck to some type of a stupid machine, I don't think we will be clinicians. And that is why medicine looks at us and laughs about this mechanistic dentist. They look at us and laugh. Reader's Digest 30 years back did the study, and they sent the same patient to 8 different dentists and said, what is the diagnosis? What is the treatment plan? They came up with minimum 24 treatment plans. And that is where we really, really fail. We don't have any consensus amongst ourselves. There is some South Indian philosophy, North Indian philosophy, West, North American philosophy. Then you have Las Vegas philosophy, Florida philosophy. We don't have a consensus. But in orofacial pain, we are beginning to have a solid, and I want to repeat that, solid consensus under American Academy of Orofacial Pain. Please look them up as well. Osteoarthritis, all this inflammation, all this information is here. It's most common arthritis affecting the TMJ. It's degenerative. It's chronic. And then you find, is it non-inflammatory? Maybe. Maybe it's just stages. And of course, we know there's remodeling. And the Europeans, they use the terms such as osteoarthrosis, arthritis deformans, whatever. The result is the same. It is something that chronically over time that causes some type of degeneration. Not a big deal. Etiology, all of these, you can just look it up. Mechanical loading, physical stress, trauma. The point is, there is so many other factors you can see here. Systemic. If you look at the systemic factors that will put in or input into osteoarthritis, you'd be like, what the heck? I didn't know. You should. Genetics of a patient, endocrinology factors, metabolic, vascular. And this is the type of education we really need, not just taking a 2-day course and jumping into treating. So please, after today's 1.5 hours, please don't start treating these patients. This is not for a general dentist or a specialist to treat these cases unless you are specifically in the field of evidence-based orofacial pain. What is the epidemiology of this osteoarthritis that you see so commonly? Guess what? Up to 20% of the population already has osteoarthritis. What do? Take all the 20%. So India has 1.3 billion people. You do the math, 20% of them, right? Multiplied by. So if you take 20% of them, multiply 0.2, are you going to treat all that 20%? No. But then why do we then look at the panoramic and say, oh my God, there's flattened condyles, let's start treating this? No need. It's over treatment. And the principle that we learned in medicine, and we took the oath of do no harm, gets into the wind. And I don't understand why. So please, if you have an osteoarthritis case, look up the systemic and then learn it in a evidence-based way how to do it. Not just flicking an appliance into everybody's mouth. That is not the treatment for osteoarthritis, as much as we know, evidence. So you know the symptoms. You have seen these cases in your practice. They come in. But remember, if they say morning stiffness, you're looking at another case more than likely. It probably is rheumatoid arthritis, maybe, or something related to autoimmune. There are other symptoms. Again, what are the other symptoms you might want to treat or refer for treatment? That's the key. Just because you saw some flattening of the condyle, please do not attempt to treat that case. Radiographic findings, how about that? Osteoarthritic radiographic findings are present in what? In 50% of the pop. This is a cardinal study, 1963. And since then, scores and scores of study have come out that says 50% have radiographic findings. What do you do? Treat all of them? No. 30% have symptomatic osteoarthritis. What do you do with those? Well, palliative care. Look into the systemic, not doing something aggressive. And please do not touch their bite. I think, in my humble opinion, knowing what I know a little bit, if you adjust the bite for treating this case or connect the patient's head to some type of appliance, we are doing malpractice, intentionally hurting that patient. Beaking, all this stuff happens, but you need to look at the progress of the disease. Is it worth managing this case? That's what we should look. And the best imaging view is usually a CT scan, so CBCT, if you really want to know. Not a panoramic, that's a most distorted view. And that's what we see. Every time I visit India and go around different cities and stuff like that, oh, TMJ, we're going to take a panoramic. That's a most distorted view of TMJ, temporomandibular joint. Please do not connect this patient's head to some type of a scanner. That would be probably scamming the patient, but don't do it if you don't have to. Look at the simple panoramic. You see some type of little baking there, little flattening of the condyle, maybe a little bit beaking here. There's a little stylohyoid ligament that is being calcifying here. So big deal. It's not needing any drastic treatment. But there are other things that we can miss. For example, the sinus looking so cloudy here. Maybe it is a snorer patient that we're going to talk about it later. But in this panoramic, nothing jumps out at me and says, oh my God, this patient needs treatment. But that's what we see now. We see this quackery in dentistry. So then we go to muscle. We talked about the scope. So there is something called myofascially induced toothaches. We just talked about to a big group of very, very interested clinicians under Manipal Education Institute, where I'm graduated from years back. And what do you need to do in that case? You will have to learn how to palpate a myofascial trigger point. By the way, myofascially induced trigger points are the number one blunders committed by our own colleagues, not knowing that if it does not fit in the toothache, this is the next best cause of a toothache. In the hierarchy, in the descending order, let's say 80% of your cases on pain on tooth will be odontogenic. The 20% is what the non-odontogenic, those are the ones that suffer like hell. And we can help them by educating ourselves and following science, literature, and evidence. So myofascial tooth pain, toothache, induced toothache is the number one cause for horrible results in dentistry because of our ignorance. Look at the masseter muscle. If you know to isolate, Kartik has learned it, and his batchmates have learned it. Around 200 people from around the world have learned it with our programs. If you can reproduce that pain on that tooth and look at the referral pattern from the masseter to the upper teeth, from the masseter to the lower teeth, this is what we see with disastrous results for the patient, the family, and the clinicians too. So let's stop this vicious cycle. Let's start doing some education in this field and say, listen, at the end of the tooth, it's not just the periodontium, it's not the periodontal ligament, it's not the apex of the tooth, it is not the nerve, it's not the gingiva, it is the rest of the patient is attached to those teeth at the end of the teeth. Let's take it in that stride and learn this science. Anterior temporalis, we have seen these medical mistakes all the time. These are the muscles that refer the pain, the trigger points to the upper teeth in a anatomic fashion. Guess what happens for the untrained dentist that does not know this fact and looks at a big filling or a previously done root canal. What do? They redo the root canal. Then it goes to an endodontic, another procedure. Then some other endodontist comes and says, this idiot doesn't know what he's doing. Let me do a better job. Then the prosthodontist comes in. Then the oral surgeon comes in, apicectomy. So basically, this belongs to orofacial pain. This is not belonging to, unless you have trained in orofacial pain, this is not your case. So what is wrong in referring a case? Nothing is wrong. So I implore us, if you, in your esteemed education that we have, if we believe that there is no actual reason, by the way, to recognize abnormalities, you must recognize what is normal. So always become a big, excellent dentist first. Then you look into these. This is the biggest medical mistake that I've seen in dentistry. Look at what's happening in the medial pterygoid. Medial pterygoid, the trigger point is here. It goes to the joint. For the untrained dentist, patient points out to the joint. Oh, that's TMJ. Yeah, that is TMJ. There is TMJ inside there. But is that the source of pain? The site of pain is what the patient points out. The source of pain is what the pain is arising from. They are different in many cases, but you need the knowledge to find out and how to test for this. That is what these succinct courses and the academies that we belong do. Look at the lateral pterygoid. Again, refers robustly to the TMJ and to the maxilla. So if it refers to the maxilla here, and you have a patient complaining over the canine tooth, guess what? End up in the same circus all over again. Trim it down out of the bite, root canal, crown, post, episectomy. Meanwhile, this guy is sitting here and laughing at us, the trigger point. So let's learn this technique. This is the huge mistakes I've seen. I had a patient who is a pediatric pulmonologist. He's a super specialist from the US. He had 4 root canals done by his general dentist in the US, and board certified endodontist repeated the damn thing 4 times in these 4 teeth. All we had to do is take a careful history, examine the patient, do a diagnostic block, and guess where it led to? To the anterior digastric muscle. Anterior digastric, this one. It robustly refers to lower front teeth. Case in point, if you have a patient that you have done or looked at or somebody else has done multiple root canals in the front teeth, and yet the pain is not going away, stop, step back, and think, is there anything beyond these teeth? Look beyond the teeth. Don't just become a dentist, be a dentist and a clinician. So look beyond the teeth and say, is there something else I'm missing here? And yes, there could be a lot missing. But the main reason this type of disaster happens is our ignorance, not an understanding that the anterior digastric muscle robustly refers to these teeth. So what are the source of non-odontogenic toothaches? Non-odontogenic. These are the ones that we unfortunately mess ourselves up, the patient and their families. Myofascial, neuropathic, neurovascular, and other. A long time back, cardiac was supposed to be big and sinus. Not anymore. We know that's not the big ones. The big ones are before this. So let's learn it the right way. What is neuropathic? Well, you can have trigeminal neuralgia, you can have glossopharyngeal neuralgia, so many other cranial neuralgias, including auriculotemporal neuralgia, which 100% of the cases, more than likely, are treated by wrong because of the lack of knowledge as TMJ. Of course, there is TMJ. Auriculotemporal nerve supplies the TMJ. 80% of that is auriculotemporal nerve. But what is the diagnosis here is what I want to drive at. Occipital and cervical neuralgias. We had a 15-year-old, the case of which we are publishing now. And there's hundreds of these cases. If you have the knowledge, then you can look at it. Deafferentation pain, a little older terminology. This one I alluded to earlier. Persistent or painful post-traumatic trigeminal neuropathy. Traumatic neuroma. This was my master's thesis, traumatic neuroma. There is so many entities under this that dentists are not taught in dental schools. We in dental school, we suck at this. A really wrong thing to do. So I feel bad for the dentists that graduate now, and I'm saying, learn it from some pioneer. Other neuropathic pains, nerve injuries. This is the scope of OFP, or official pain, with neuropathic pain. This is another quackery that I've seen. Patient has tinnitus, ringing in the ears. What do the dentists say? Oh, I've taken a 5-day course or 3-day course in, let's say, Nevada, New York, Nevada, USA, or something with Florida, or some other place, Western somewhere. And they say, oh, I can treat tinnitus. ENT patients, ENT specialists, ear, nose, throat, otorhinolaryngologists, they don't know to treat this, and they agree. The good ones say, we don't know this. Meanwhile, dentists who took 2 days of course, oh yeah, I know to treat tinnitus. It's not only malpractice, it is absolutely, absolutely wrong to tell a patient, I can treat. And definitely, it's not attaching this patient's head to a machine. So it's tinnitus. We know some reasons that we think of in the orofacial pain spectrum that can cause it. You take the course or some succinct course, you will understand. But it could be from a muscle that we know. Case, there's a 12-year-old African American female. Pain started on the left and right face around 11 months back. Slow onset. Cheek also hurts. Preauricular region. Untrained dentist? Oh, that's TMJ. Of course it's TMJ. It's chronic, right? Frequency multiple times a day, minutes to 30 minutes, 3 to 4 on a visual analog scale. It could go to 8 to 10. Aching quality. Chronic slow progressive. Aggravating factors, chewing, yawning, talking. Oh, yeah, it's TMJ. Of course it's TMJ. But what is the diagnosis here? We don't know yet because we need to check the history completely. Tongue thrust, anterior open bite. Guess what the orthodontist did? Started looking into treatments for tongue thrust. So let me ask you this. If a patient has class 1 bite and then due to some reason develops an anterior open bite, do you have a diagnosis already where the tongue is resting forward? It's tongue thrust? Or should you look into something else maybe? These cases we see now, I saw 2 cases at Rutgers, both from orthodontists. For all those orthodontists out there, tongue thrust in a 15-year-old or 12-year-old really doesn't open up that bite all of a sudden. Let's look at other, maybe it could, but let's look at other causes, right? What if the condyle is losing its height? Okay, that will open up the anterior bite. Look into this, right? And these orthodontists should be taught this. Unfortunately, they're not taught. So I urge you, to whoever is not taught that, to go into literature and look at anterior open bite occurring in a, let's say, adolescent. Is that tongue thrust or is it something else? In any case, this patient is sleep disturbed. Of course, general dentist did what? Bite adjustment, removal of interferences. As a matter of fact, interferences is not in the patient. The dentist is interfering with this patient's life. That's the problem here. And orthodontic treatment was recommended. Fine. There, somebody did some soft appliance, some hard appliance, all that nonsense. It didn't work. Then the specialist said habit breaking appliance, severe tongue thrust. Okay, fine. Medical history, anxiety, depression, vitamin D. Now the thing is unfolding, right? It's unfolding. So the onion peel is slowly going away. So now anxiety, depression, anemic, irregular menstruation, cold sensitivity. I mean, what does this have to do with pain? Everything it has to do with pain. So, and also now she has dry skin, muscles hurt sometimes. If you know to ask, the patient will tell you, or the patient and the parent will tell you. If we are ignorant, patient is not going to tell you. They only know to show you where it hurts, the site of pain. It is our responsibility to let know and to figure out, peel the onion to this core and figure out the source of pain. Okay, so on cold exposure, she has blue fingers. Look at the panoramic, and the orthodontist saw the panoramic. That's the most amazing part of this. The condyles are missing in this. These are the condyles that is missing. This is a case of severe juvenile rheumatoid arthritis, and not that uncommon anymore. Horrible, horrible results if you try to put this in as tongue thrust and start doing tongue thrust appliances. What do you see? You see a patient that had multiple root canals, but done by 4 or 5 dentists on the upper left side. This is a case of TAC, trigeminal autonomic cephalalgia, which is a cluster headache. Cluster headache is a form of TAC. The orofacial pain encompasses how you will diagnose this case. That's the beauty of the subject. I can tell you with no doubt in my mind, looking at all the 12 specialties, this is the branch that dentistry blends seamlessly with medicine, and I love it. There's no other. I love all the specialties for their own reasons. But when you have pain, you are not with the prosthodontist, you're not with an oral medicine person, probably, you're not with a radiologist, you're not with the endodontist. You can, but if the endodontist is the question, I think the hierarchy should be, and I feel that it should be a person that is properly trained in orofacial pain. So those of you who are endodontists, if you're looking at this case, what the hell is happening here? We had, what is it, 4 or 5 root canals. We had one root canal here and an extraction and a graft. What are we thinking now? Well, this was a case of, cluster headache. All you need to do is put this patient on oxygen. That kills the pain. Who knew? Trigeminal autonomic cephalalgia. These are the ones we have under this. So cluster headache is that case that I just showed you. Of course, that is a litigation case um, because 4 or 5 dentists failed to either refer or both, okay, to refer or correctly diagnosed, because those are irreversible treatments. You cannot do irreversible treatment. You cannot open up the chest and go to open cardiac surgery and say, oh, nothing was wrong with the heart then. Are you kidding me? You opened up the chest for that? So same way we will be judged too. So please learn the subject and let's do referral if you cannot learn it. You see a familiar face here, kneeling down and smiling like a Colgate smile or close up or whatever you want to use. Smile here. That is Kartik in this amazing batch of approximately 20 plus students taking 150 hours, not 1.5 hours that I'm giving you now, 150. And then there is another batch of students will take 250 additional hours. Is there anybody in the audience that can think of 400 hours these amazing people are taking and think that it can match what the 3 or 4 hours or 3 days of a course somewhere in an Indian city or US city they can come close to? So please understand there is a branch, there's a specialty that really needs to be understood. And be proud of your courses. Be really proud. We are proud of the courses and we are thankful to our facilitators in India as well. We looked at the scope of orofacial pain, cardiac cephalalgia. Why does heart attack come on the teeth? Well, there is an explanation, neuroscience based, because the pathways that go from the heart pain and the face pain or jaw pain or hand pain or neck pain, they follow the same pattern and they end up in the similar nuclei or similar areas in the spine, similar areas in the thalamus, similar areas in the cortex. So that sort of oversimplifies. I'm just oversimplifying this. This is not just one diagram. This has to be learned. And there are patients who have had this in the dental office that the dentist had absolutely no clue how to diagnose. Well, learn the technique. Then we talked about orofacial pain, tooth pain affecting hands and stuff. This is the case we have published, and we have published again, and we're publishing more cases where dentists, we thought, including endodontists, including general dentists, including oral surgeons, we thought, and including myself as a general dentist, that these are cases that are teeth related. But at some point when the patient said that too, that pain is going to my hand and neck, we thought, what is the diagnosis? Psychogenic pain. A big point about psychogenic pain. Until 2005, that's when I started my orofacial pain career. 2005. It's been 15 years. It's been a long time. Until that time, I did have a lot of psychogenic cases, okay, in my practice, because I started practicing 1999 and until 2005. 6 years. I was so good. Beautiful aesthetic cases, this and that. I was so happy. And I said, oh, okay, I don't recognize this, must be psychogenic pain. In 2005, 2006, something miraculous happened. The psychogenic pains had a steep downturn, and I had recognized because tamasoma jyotirgamaya, right? Because my ignorance, my darkness of ignorance was slowly being dissipated by the light of knowledge in this field. And I could just see clearly, oh my God, it is not that the patient is psychogenic. I am the idiot in this. So I stood up and I started taking courses. And I urge you who are listening to do the same, or at least think of the same, or refer the patient, either way. These cases are there. You will see it in your practice. If you can recognize it, good and well. If you cannot and you don't understand, refer the patient to at least one of the 31 people and more coming up, because India is 1.3 billion. I cannot imagine. US is only 350 million, and we see a lot of cases here. I can only imagine how many cases are walking around in India with this. Toothache from auricular temporal nerve. Yeah, this case would be really misdiagnosed, right? Most general dentists have no clue what this is. Let's say 99%. Specialists, 99%. They have no clue. And then where does it belong? Well, you have to work up these cases. And of course, the patient say, oh, yeah, that's the tooth. Well, do the root canal, kill the nerve. I'm telling you, that was unnecessary treatment, irreversible treatment, and we are responsible. Oh, I didn't know. Ignorance is not an excuse anymore. We have a specialty, we have courses, we can learn, we have literature, we have evidence, we can learn. Please look at this one. Um, this is that proverbial nerve that we learn in certain dental schools. Must be that upper would be like MB2 canal that just sits there and hurts the patient forever. Okay, it must be that distal buccal canal, that little fiber that sits there and just eludes itself from all these toxic things we're pumping in, right? The Clorox, the hydrogen peroxide, the what is that? Chlorhexidine gluconate, water, whatever we are pumping in, EDTA, this nerve is just shielding it one fiber, like a hair thin, shielding it and saying, I will not die. I refuse to die, and then causing pain. What type of nonsense are we talking about? I put a little subheading there, case of the sciatic nerve. I work with sciatic nerve on rats and mice. That is my thesis, and that is my stuff that I've done from 2005 2006. You open up the sciatic nerve to the air, it gets affected. You leave it for half an hour, it dies without the medium. So what are we talking about? What nonsense have we been talking about, that MB2 canal in the upper, or a distal buccal canal, or a mesiobuccal canal, just surviving all the rigors of this climate around it, and just hurting, and hiding from you? It ain't happening. So let's look at these cases in a different perspective, which is what? Scientific perspective. Not because somebody told you it works in my hand. Let's think a little bit. Let's use this upper chamber not to be dental people, but to be people of science. I urge you. We have another component added to now this one, that is called sleep medicine. So what do we have? Why sleep medicine at all? This is the Bible of sleep medicine, by the way, or we can say the Bhagavatam of sleep medicine, or Quran of sleep medicine, whatever you want to call it. This is the cardinal textbook, 2,000 pages. So why sleep medicine? Well, obstructive sleep apnea has been known and shown to cause, aggravate, perpetuate. If you have a patient in your practice that is on 2 or more antihypertensives, please look at their sleep patterns and you will find out you might save a life. That's all I'm saying for this now. Metabolic syndrome. In the US, it's 50% of, I think, US population is just obese, just fat, it's obese. And I think India is following fast, because Kerala, 100% literacy, but metabolic syndrome, because of the stupid food habits we have, is on the rise, big rise, and it'll bring you more patients. Okay. Now, combine that with COVID, it's going to be horrendous. By the way, those students of mine that have taken the course, I guarantee you, by the time we are done with COVID, or COVID is done with us, there's going to be such a surge in orofacial pain cases. You're going to see it with concomitant depression, suicidal tendencies, schizophrenias, anxiety, all of the comorbidities that come with TMDs, headaches. are guaranteed. I'm going to tell you this, predicting this. Your practices are going to thrive with these patients because there is no one else will be able to delineate. You will be the captain of the ship with the neurologist referral, ENT referral, pain management referral, oral surgeon referral. You will be the captain of the ship for this. Type 2 diabetes, obstructive sleep apnea causes type 2 diabetes. ADD, ADHD, if you know an attention deficit hyperactive disorder kid, please look at the sleep habit because uh, lack of sleep and sleep disturbance have been shown to induce this. And reversing that sleep problem has been shown to stop ADHD. So please look at that. Erectile dysfunction has to do everything with nitric oxide. That is the neurotransmitter common to sleep and erectile dysfunction. Stroke shown, coronary heart disease, sleep and pain, and more and more and more. So then we talk about sleep, the stages of sleep. This is an older classification. I'm I'm going to only tell you because we have 1.5 hours to condense my 15 years with Karthik. We have stage two. This is stage two. This is stage three combined. Most of our brux, sleep-related bruxism happens in stage two. Let us please stop telling our patients bruxism is because of the bite. It's not. Let's please stop patients explaining to our parents that, oh, your child is only 8 years old, it's mixed dentition stage, that is why the bruxism there. What nonsense have we been saying? Because this thing generates from the brain, centrally generated process. How the heck can teeth be any part of it? The effect that we see on the teeth are related to it. The effect of the teeth, effect on the teeth or dentition, okay, you can classify that as a resultant, secondary to bruxism. It does not cause bruxism, absolutely not. Sleep-related bruxism is not caused by bite, not caused by occlusion, not caused by interferences. So stop attaching their head to some type of machine. You can do a sleep study. That's an entirely different thing. That's an entirely different specialty and a subspecialty. So here we have, and most of the bruxes brux here. This is just a pearl for you guys. If you have a patient who is bruxing and shearing that porcelain off your PFM or the class 5 lesions, abfraction, toothbrush abrasion, all this stuff we talked about, define, redefine the redefinition. Let's stop and look at science, right? What is important in this? So this is why I have the passion for this field because it's integrally related to sleep and pain. They are integrally related. They cannot be separated. I get these Facebook messages, texts, and calls, and doc, I want to just learn OSA. Okay, I want to just learn pain. I'm telling them no, no, and no, because you have to learn both together. They are combined, and more robust literature is coming out that is saying it's combined. So let's act succinctly. There is a class of sleep-related breathing disorders, and obstructive sleep apnea is one of them. Obstructive sleep apnea is one of them. Health effects of snoring. Who thought snoring was related to cardiac problems? Who thought snoring was related to hypertension? Who thought snoring might be related to strokes? Well, we know now. So snoring itself can have problems, right? Sleep-related movement disorders. This is the stuff that I love teaching because look at what is in there. Sleep-related bruxism. It is a movement disorder classified by American Academy of Sleep Medicine. There's a consensus paper that has come out in 2019 that says slightly differently, but guess what? American Academy of Sleep Medicine's classification is still the same. And consensus can be changed next year probably. I keep it and I take it with a pinch of salt. But let's understand that sleep related bruxism has nothing to do with the bite, nothing to do with occlusion, nothing to do with collapsed bite, nothing to do with the denture, nothing to do with the crown, nothing to do with interferences. It has everything to do with the brain, the motor cortex. And you cannot adjust the motor cortex by adjusting teeth. That would be stupid. So let's stop saying and teaching our children and our next generation of dentists that this is because of mixed dentition. This is because of a bite change. Let's stop this nonsense now and let's look at the literature. Anyone has questions? I will guide you to the literature if you want. Look at the cascade in bruxism that is published in the Bible of Sleep Medicine. Look where the tooth contact is. Guess what happens the first? Sympathetic tone. What? Oh, yeah, sympathetic tone increases. Parasympathetic tone decreases. I don't know about that. Well, go back to physiology. Guyton, Ganong, and Chandrasekhar, whoever was that other one in India. That's beautiful textbooks. Go back to it and see why there is an increase in heart rate. Why does it breathe heavily? Why is an EMG activity increase before the bruxism happens? What? Yes, this is literature, and this has been published in the Bible of sleep medicine. Meanwhile, what do? Tap, tap, grind, grind, adjust this, adjust that. That's our range. That is unfortunately our range. So bad. So let's change this and look at what is in the literature. Okay. And the splint has nothing to do with treating the sleep bruxism. It can protect the teeth. Yes. It can probably reduce myalgia because of the less contraction of temporarily. The oral splint works literature temporarily. 3 weeks later, everybody grinds happily ever after on the same splint. 3 weeks. That's it. I'm not going to the too many cases because of our time limit. And remember, I'm blending it into 15 years into 1.5 hours. So the proportionate is not that good. But understand multiple specialties and dentists and general dentists in multiple countries see this type of patients, and they don't know what the heck it is. They all know, well, I learned in a 5-day course, I learned 1 month, trigger point injections, occlusal adjustment, prosthodontist, neuromuscular dentist, and all of the other stuff. And then they're like, I don't know what it is. Guess what this case was? This pain was because the patient had 3 years to live. It's a glioblastoma that is appearing as a TMJ case. And this is not just this. This is vestibular schwannoma. This is pituitary adenomas. These things come up and we catch them one by one. Well, this one was a tragedy because guess what? You have a glioblastoma. If you have that and you treat for TMJ and connect the patient's head and neck to some type of stupid machine, we are not going to win this case, right? Because we failed to recognize the red flags in this case. And this happens more often than we think. Case 61-year-old Caucasian female, bite changed by several dentists. And this is the classic picture. Okay. After the first dentist, the second dentist, third and fourth and final, and then a specialist will come up and say, hey, I took this 2-month course. I can't wait until I get my hands in your mouth. Well, they all did this. And then they went to a TMJ doctor, which never existed when this case was published. Guess what? It's the tragedy that is beginning to happen. Several dentists, she cannot feel the bite anymore. Then TMJ appliance. Oh, yeah, the upper appliance, the lower appliance with a ramp, with the canine rise, group function, pink appliance, blue appliance, appliance with Christmas lights, appliance with bells on it. Every damn thing has been tried. Guess what? No effect. What? I thought what I learned from that person in Maryland is that I should have the appliance mounted on a semi-adjustable articulator and adjust the spots very carefully, then adjusting the patient in standing, sitting, lying down, and upside down positions. No, this is not that case. The new dentist evaluated, so he's going to fifth or sixth dentist. Oh, I think the bridge is out of occlusion. Let's correct that. Okay, now the bridge is ground down to a point that is showing metal through the porcelain, and then the whole of the porcelain chips off, right? You have seen these cases. I will not blame any dentist for doing this if they stop there. But if you are not knowledgeable and you don't have the incentive to seek new knowledge and science, and we treat these cases irreversibly harming the patient, we just committed malpractice, we committed a crime. If you don't know, refer, please. And we checked with the mylar. Oh, what a beautiful, I mean, I had goosebumps when I looked at it, right? Nothing wrong with the bite. So then where does this patient go? Psychiatrist. That's the worst thing you can do, right? This is a case of what we call occlusal dysesthesia. Occlusal dysesthesia. Where does that belong? It belongs to somatoform disorders and somatization disorders. There is nothing the dentist can do in this. And the more you do, the more these patients get messed up. I know you have seen these cases. That is the case that with the 3 unit bridge will come to you and say, a little bit more, a tad more, doctor. I feel that little bit more. You grind it. I feel much happy. 1 week later, that's the what you did was phenomenal, phenomenal, phenomenal. But you know what? On the left side, I have one more spot. I can feel it. Okay, tap, tap, grind, grind. Whatever you learned in your dental school, grind a little bit more. In the end, it continues and continues, and the patient is never happy. He or she goes to the next person and says, that is an idiot, and I know you're the best. When the patient says you're the best, don't treat that case because you might be in trouble. Because 6 of them did the same, and you have no additional knowledge in this, how can you be better? Oh, I'm a specialist for the last 15 years. Doesn't matter. People practice the same mistake for 15 years and they call themselves experienced. So the same error committed over 10 plus years, 15 years, it cannot be called experience, right? That's still an error. So this is a case of occlusal dysesthesia. And we have case after case after case. This is a pituitary adenoma. Who knew? Well, you would know if you knew the lesion was there. We have to order an MRI. Well, what is a dentist doing in MRI? Learn the technique, learn the science. That's the beauty of it. Case number 5, TMJ pain, electric, burning pain. I do not like to get numb because the numbness lasts for. If a patient says I get numb for half a day, you should be really, really, really careful. Okay. From Virginia, there's a guy I told you, a quack that was on some videos that said, "Okay, I can put a plate in your mouth and you will walk." Hallelujah. Or God saved him. No, it's because they did not understand neuroscience why this happens. So visual blurring was because of TMJ, right? TMJ, visual blurring. Can you imagine this? Because of TMJ. Guess what it was? Multiple sclerosis. Great job adjusting the face and connecting the patient and then adjusting the teeth in a case of multiple sclerosis. And this is not just one case. This is multiple neurodegenerative conditions presenting as TMJ and facial pain problems. The blind leading the blind. Dentists referring amongst themselves. And that is why orofacial pain is the next new specialty, which is the 12th specialty under dentistry. 68-year-old male, throbbing pain. 5 general dentists have seen, 2 physicians, 3 oral surgeons, 6 general practitioners said, oh, we need a full mouth rehabilitation. And then the patient looked up from the Google or something. There is a specialist in Las Vegas, full mouth rehabilitation with implants. What a beauty, right? They have high cholesterol, triglycerides, fatty liver, all that stuff. Okay. Good fitting dentures, partials they have. What do you see? Well, her external carotid artery is calcified or calcifying. This is the calcification. And that is causing significant reduced blood flow. Thereby, she will have what? Claudication, pain on chewing. The poor patient has no clue what is coming her way, right? External carotid artery. Again, those calcifications narrowing the carotid artery. It can be seen many times on a panoramic. Who knew? Well, nobody taught you. Well, you find out then. External carotid artery calcifications. You can see it clearly in this panoramics and the other films on patients. Case number 7. I'm not going to go into the details of these cases because we have no time. The same circus repeated again. Equilibrations, redo crowns, restorative, 4 appliances, medications, 5 dental specialties. No one has a diagnosis. And the patient is having face pain and migraine. The question is, when do we stop? This is a myofascially induced toothache case, myofascially. And when do we stop this type of nonsense? We need to stop it now. And I implore you to look into the best cases, the courses. We have a couple of slides on that. This is my mentor slide, and I've shown this quite a few times in my grand rounds. When do we stop? We usually stop when the last tooth is finished. This 28 teeth are finished. They're looking for the 29th. It's not there, so we stop and say, I don't know what it is. let's start with the first root canal, right? So then how do you become an ortho specialist? You have to learn more. Evidence-based courses, and I'm proud of the one that I told your organizers. I will show a couple of slides of it. Proud of Smile USA, Dr. Shankar Iyer, and the team that is with them, and the courses that we brought to Chennai, to Mumbai, to Bangalore, to Delhi, to Calcutta, to different cities in India. Document your CE. If you're taking one course of 6 hours, document it. Go to these websites: American Academy of Orofacial Pain, American Board of Orofacial Pain, International Association for the Study of Pain. And our latest one is we are starting, it's IOS, the Eastern Hemisphere. Please go into this website. The courses that we offer are specific to orofacial pain, specific. And yes, Dr. Iyer and other eminent faculty will teach you what, without mythology, will teach you what occlusion and bite is all about. No myth, proof, evidence, literature. And these are the courses. The next one is coming next month. We are excited. And it's coming. And there is Mr. Balaji Subramaniams, Arlene Fernandez, and Dr. Satish Devarajan from Chennai. They are our representatives. Satish is actually in the mastership course. He's a great guy. He's a prosthodontist who took it upon himself, humbled himself down, and said, I don't know this, so let me learn what? 400 hours. So this is the beginning of that. And it's starting globally, not just in India, but this is the brochure for India. And there's 3 steps to it. Believe me, you go through such a course, you will begin to understand how much you do not know. And that was what I did 15 years back. We have eminent faculty from around the world, and some of them my former students who have become now super teachers. And that's what I love about my course. Again, one more time, we have a full 1-year program, the mastership, which is what more than likely Kartik will be taking, starting hopefully November, December. They'll be transitioning into the mastership program, which will, at this point, make them eligible for the American Board of Orofacial Pain to appear for it and get certified. We live in the greatest time in dentistry. There is hope for a lot of these patients that are hurt by ignorance, hurt by some type of arrogance or pure criminality. We can help them. And I thank the organizers for bringing this course to your organization. I thank Kartik. These are the people from our graduation in Manila. Great bunch of people. And please remember, real knowledge makes you humble, not egoistic, humble. I never would say, in my hands it worked. If I said it, that's because I don't know. I'm just telling you, it worked in my hands. You want to work and see? That's fine with me. So real knowledge makes you humble. I thank all of you for listening. I thank the organizers and Karthik. Thank you. I'm going to switch now to get out of my mode here, and I'll switch to Karthik. Karthik, whenever you're ready.
Yes, sir. Good evening, everybody. Is my voice audible?
Yes, Karthik, we can hear you clearly.
Yes, thank you, sir. So with folded hands, I thank the organizers and my mentor, Dr. Davis Thomas, for giving me this opportunity to present. And I am humbled, and I pay respects to my parents who are listening to this live Facebook session, and my teacher and guide, Dr. Abhay Kamra, who was my postgraduate guide in endodontics. So I pay my respects to all of them, and I start this presentation. So I'll be presenting 2 cases. And as Dr. Thomas rightly said, that he's been so humble in saying that 25 years of his experience in dentistry and 15 years in orofacial pain is a very humbling experience. So I am just a young, I'm just an infant in this field, and yet it's been such a humbling experience to even touch this field of orofacial pain. So a 24-year-old female presented to us with a complaint that, doc, my face is on fire. And when we went into the history of the presenting illness, she said it had a gradual onset over a period of 6 days, and the pain started when she started her orthodontic treatment, when she's put in the braces in the maxilla and the mandible, and the pains, some sort of pain she started experiencing on day one, and then the pain transformed itself into a burning kind of a pain, and started with the tip of the tongue, then the whole of the tongue, then the whole of the lower lip, and this started on the night of the fixation of the rapid maxillary expansion. That's on day 3, and the burning pain kept on increasing and started troubling her. Started having sleepless night, and now she feels. I saw her on day 5, and she said to me that the whole face is burning. मेरा पूरा मुंह जल रहा है. That's how she articulated herself in Hindi. And when I looked into the history, a detailed history, a 7-page history, I could see that the location is the tip of the tongue, the lower lip, and the face. There's no chronicity since it was it started in a very short period of time. Frequency daily and continuous burning kind of a pain. Duration is the whole of the day and night. And on the visual analog scale, the intensity is 7 to 8. That's acute. Quality, burning, pricking kind of a pain, and it is acute and progressive in nature. The aggravating factors included when she sat for studies, it aggravated. When she started to Google what is going on with her, it aggravated. And when she was given topical steroids for application, it became very severe. Relieving factors were sleep, that is after some period of burning, when she went into proper sleep, that is deep sleep, then she would forget about it, and that used to relieve her pain. Then she sat for prayers or meditation, that relieved the pain. And Caterol DT, that is piroxicam, for a period of just 3 hours. So when I took her case history, when I met her, when she consulted me, she had already taken 8 tablets the previous day and already consumed 5 tablets the time she met me. The pain was referring to the palate and the upper lip also, and the sleep was disturbed until 15 to 20 minutes. Other aspects of history, she was completely okay with respect to the other systems. The head and neck screening was completely normal. Yes, when I took a deep psychological history, she was very emotional, and when I spoke to her mother also, she said yes, she's a very brilliant kid and pretty emotional, very sensitive kid, cries easily, disturbed easily, very worrisome in nature. Cervical screening was also within normal limits. Habits, she had no habits to say. Sleep history, sleep was disturbed for the past 5 days at the onset, but once the patient was asleep, it was okay. Past treatments included topical steroids, vitamin syrups, B complex capsules. The patient was thought to be having burning mouth syndrome, so was given clonazepam tablets also. And she took up a tablet and it didn't work, so she stopped it. Then, as I had said before, she took Caterol DT piroxicam, and benzocaine jelly also was applied on and off, which did not give her much relief. Specialist visited, so she was undergoing orthodontic treatment, so an orthodontist and a maxillofacial surgeon and a dentist also was consulted in the same clinic. So she was thoroughly examined. All the muscles of mastication were examined, so I did a proper muscle palpation. Other than the lateral pterygoid, I palpated all the other muscles, anterior temporalis, posterior temporalis, masseter, the sternocleidomastoid, the posterior cervicalis, suboccipitalis, and all the muscles mentioned. So it was not significant. The TMJ evaluation was also completely normal. The joint palpation also was, there was no pain on joint palpation. And intraoral examination was done. Some photographs were taken, and what I saw was simple class 1 malocclusion, impacted third molars. Mucosa, gingiva were completely normal in the maxilla and the mandible. Extraoral examination, everything turned out to be normal. Radiological examination, yes, protruded maxilla. I spoke to the orthodontist, saw the panoramic as well as the lateral cephalogram. Nothing was very significant. These are both the x-rays that we could see. I think I'm speaking a little faster than the slides. these are the intraoral photographs with the rapid maxillary expansion screw in the maxilla. As you can see, the gingiva is completely normal, the mucosa is completely normal. So it was not. So I also thought about burning mouth syndrome or Sjogren's, but and also I had a doubt in mind about the fibromyalgia aspect also. So I did a complete thorough workup of all the painful points that could be in a fibromyalgic patient, but everything turned out to be completely normal. So the screening for fibromyalgia was completely okay. All the lab tests were normal except for vitamin D3. She was deficient in vitamin D3, and proper supplements were given. So luckily, there were no tender points for the diagnosis of fibromyalgia, according to Hauser. As you can see, these are the tender points that we examine when we have to delineate fibromyalgia for any patient. And this is the myalgia profile, all the lab tests. There are more, but this is the main test that I enumerated in this particular patient. And as you can see, the D3 is not normal, it was deficient. So we also evaluated her for to eliminate Sjogren's syndrome also. So she did not have any other complaint like difficulty in swallowing or dry eyes or corneal ulcerations or any other peripheral neuropathy in any other part of the body, no dry skin, dry mouth. So, and also for burning mouth syndrome, like all of us know, burning mouth syndrome can be primary or secondary. Primary, there is no there is so once you evaluate, so burning mouth syndrome per se is a diagnosis by exclusion. So once you completely exclude any other causes of burning mouth syndrome, that could be vitamin deficiency or iron deficiency or issues with the total iron binding capacity or candida infection. So then we come to the diagnosis of primary burning mouth syndrome. That's a neuropathic issue where there is a I could say a short circuit between the chorda tympani and the lingual nerve supplying the anterior 2/3 of the tongue, but she did not have anything. So the diagnosis is like sir mentioned to you before, uh, peripheral post-traumatic trigeminal neuropathy. It was also earlier called PPTTN. Now I will not go into lot of detail about this because this is beyond the purview of the time as well as the scope of this 1.5-hour lecture. But what happens is any nerve or axon is exotomized. The there is neurogenic inflammation, and then there are so many mediators that are released, and these in fact trigger the adjacent neurons, the C fibers and the A beta fibers, and once they are triggered, then the ganglion, they pass on to the ganglions, then to the spinal cord, and then it goes on to the higher centers. And there is not only a peripheral mechanism but also a central mechanism is triggered of pain. Dr. T could sir, would you like to say anything more about post-traumatic trigeminal neuropathy? Hello.
Kartik?
Yes, anything more, sir? Would you like to add about PTTN?
Yeah, I just only thing I would like to say is any dental procedure we do, including just deep cleaning, like I mentioned before, or even anesthesia, can end up in such a thing. The main thing is the dentist should be aware of this and hopefully recognize and refer this at their with the lack of training we have. If not, then they can, because this can come in various forms and it can confuse the heck out of even a seasoned dentist. So you need the training, and that's my key when I refer to this with your batch and any other fellowship batch to begin with.
Yes. Thank you, Dr. T.
Welcome.
So this is the diagnosis and the treatment. So as you can see, neuropathic pain is very different from the nociceptive pain, that it is radiating or it could be specific. The typical burning, the typical quality or the patient description of the pain is very critical: burning, prickling, tingling, electric shock like or lancinating. And the mechanism of pain is typically a dermatomal, And like you can see the clinical example, it could include trigeminal neuralgia, post-traumatic trigeminal neuropathy, and we are speaking about PPTTN or post-traumatic trigeminal neuropathy. And we ended up giving her an appropriate tricyclic antidepressant, and vitamin D was treatment was initiated, and cognitive behavioral therapy was a very important aspect of this particular patient, because the patient was very nervous or very disturbed and very worrisome. So 2 sessions with the patient made a hell of a lot of difference, and you would be very happy to know that just one dose of the appropriate antidepressant, uh, the day she met me, I started the antidepressant in the night, and the next day she was completely fine. So we continued the drug therapy for 15 days, then put it to half a dose, and then slowly we tapered off. And we have already told the patient that this could be a recurring phenomenon. If it ever recurs, she has to come back and let us know. Now, something so critical about this particular patient is this patient belongs to a very eminent family and has n number of doctors in the family, and they were also clueless about what is going on. So these are very baffling things, and I am very sure that in our practice, like I've been practicing for 15 years now, I have seen n number of patients which I didn't have any clue about what is going on with the patient. How do you treat burning pain? How do you treat prickling pain? And this is a platform which gave me an idea, which gave me the confidence, this gave me the humility to take a proper case history, evaluate it meticulously, and relieve the patient of whatever pain she was undergoing. Another case which Dr. T has diagnosed for us last year, and this is a female, a doctor, married, a 40-year-old female, and complains of pain and clicking in the right jaw since the past 2 years. And in the history of the presenting illness, we could see, oh, I'm going a little bit fast, just a second. So when you come to the history of the presenting illness, so the pain increased gradually over a period of 2 years, off and on. So pain and clicking increased together. Background pain was always there, and all of what happened 2 years back was that the jaw got stuck during a dental appointment, and the mandible and the dentist could put it back in place, and the doctor gave her a soft splint, and everything was okay for 2 years with the splint. She was wearing the splint off and on whenever she used to have a little bit of exacerbation, but the pain started becoming severe. So she visited us, and in the detailed history of presenting illness, we saw that it's a right preauricular region. It's a chronic kind of a pain, and frequencies, it's a daily pain, and there is a continuous background pain which with intensity of 2 on the visual analog scale, but when it increases, it goes to 7 to 8, very acute pain. The acute pain lasts for a few hours, but the background pain goes on throughout the day, throughout the night. The pain is described by the patient as pressure or holding or pressing kind of a pain, and it was chronic and progressive in nature. Aggravating factors, the supine position used to aggravate it, and the patient for almost 2 years never slept flat. She slept with a pillow on the backrest and slept at an angle of 45 degree or 50 60 degrees. And daughter's studies, daughter's exams, or any stressful situation always aggravated the pain. Relieving factors, now it's pretty surprising, her husband's presence relieves the pain. Now this is very uncommon to see. Exercise, running. She's a painter also, as a hobby she paints, so that used to decrease the pain. Analgesics decrease the pain only for a very short time, but she's a runner. She's a very rigorous in meditating and yoga also. So I'll show you in the subsequent slides. You can tell her to do any yoga pose and she will do it immaculately. And the referred pain is to the temporal area. Sleep, yes, it is disturbed. When I reviewed all the systems, other than the cardiovascular system where she has a pacemaker installed, all the rest of the systems are normal. Head and neck screening are normal. Psychological history also, I could see that she's a very emotional female, but very sensitive kind of a person, and a great patient because she listens to the doctor completely. At the same time, very authentic, puts everything on the table. That's one of the reasons we could treat her, we could manage, support her in managing this issue so well. And habits, she just has a simple coffee taking habit for twice a day. Sleep history, yes, this is very prominent, as Dr. T pointed out correctly, that sleep and pain are very robustly connected. Sleep affects pain and pain also affects sleep. So this is completely a mixed bag, wherein the pain never wakes her up. But what is important is she wakes up three times in the night at least, and she has mild pain on waking up. No sleep bruxism, that's, and we interviewed her husband and her daughter also, but she feels tired throughout the day. She has trouble going on to off to sleep, and there's a long latency period, but and sleeps also late. It takes her almost 2 hours to go to sleep, so she sleeps by 12, but she has to wake up around 4 o'clock or 5 o'clock. Specialist visited, she has visited dentists, orthodontists, maxillofacial surgeons, prosthodontists, orthopedic surgeons. One thing very important about the history taking is the way Dr. Thomas has trained us in this fellowship batch is to be physicians, is to is to is to really investigate the case, not just try to chalk out treatment plans and chalk out some reimbursement policies, but to actually go into the nitty gritties of the case. And when we started taking her case history, whatever we said turned out to be true. Now, she was always called a very clumsy child. She used to go on, keep on banging her feet or head, and keep on having falls in her childhood, bruised everywhere. And she had issues with her vision also. And this clumsy child tag always remained with her, and she didn't know why. When Dr. T examined her thoroughly, when I had the opportunity to take a case history, we came to know that she has a connective tissue disorder, and not a major one, luckily, but in the case history, this is what came out. So we could also come to know, we also came to know from the case history that she was labeled as a psychiatric case. She was on 2 antipsychotics for a period of 6 months, where physicians, she had a small orthodontic issue because she's a runner on the left knee, and she was labeled as a psychotic patient. She was told that she has a functional pain, or I have heard physicians saying that whenever they cannot diagnose any pain, the patient is, he or she is labeled as a psycho, and she was labeled like that. But her husband never gave up. He took her everywhere, and finally he came to know of us, brought her to us. We evaluated the case. So if you can see that her maximum active opening is 38 millimeters. We evaluated the TMJ also thoroughly. Protrusive, left lateral, right lateral. We evaluated everything, all the muscles of mastication, few muscles of mastication, especially the superficial masseter was a little painful, not little, but had severe pain. Rest of the muscles were okay, but we could see that she has some or the other musculoskeletal issue. That is what we could see even on joint palpation. That is on the right TMJ, on the lateral aspect, she had quite severe pain. So when we evaluated the panoramic, we could see that the condyle is not exactly the way it should be, but the issue was not with the condyle. So she had a typical class 1 malocclusion, impacted third molars. Luckily for us, she came to us at the right time. She was told to extract all the 4 impacted teeth and asked to get a full mouth rehabilitation done and all sorts of things. So if you see the Byton criteria, this is a criteria for evaluating the joint hypermobility syndrome. And if you see, she could do every pose of yoga the way it was meant to be done. And if you see her, the patient, turning to the left and the right, it was horrifying to see how much she can turn. And when she touches the chin to the sternum, that's also pretty amazing to see. And if you could see, her left thumb is has a steep turn, and these are some of the characteristics of joint hypermobility syndrome. The important thing, as Dr. T pointed out, is not treating the patient, but supporting the patient with a diagnosis and counseling the patient with cognitive behavioral therapy. 45 minutes spent with Dr. Thomas and us, the whole fellowship batch, was enough for this person not to consume one painkiller in the last year, and I'm so happy and proud of this fact. So we did a thorough fibromyalgia profile evaluation. So luckily, my friend is completely normal. None of the tender points existed, except for the knee where she was operated on. And the final diagnosis was right TMJ, arthralgia, and hypermobility syndrome. And as I pointed out earlier, that a simple soft diet, stabilization splint for to temporarily unload the joint. Some joint exercises which were taught at Rutgers. Sir was kind enough to hand it over to me. I trained the patient in doing these joint exercises, and cognitive behavioral therapy, of course, is a blessing in disguise. Counseling the patient, and patient has learned to manage her life with this and is living a very powerful life. She exercises, she practices, she's doing whatever she's meant to do. So I am very humbled by this learning under the mentorship of Dr. Shankar Iyer and Dr. Davis Thomas in particular. And what I want to point out is my thanks and appreciation for this particular learning, wherein everything for me was in a tunnel vision, that as an endodontist, as a teacher, as a general practitioner, everything started with the tooth and ended with the tooth. This learning gave me an opportunity to be more and more humble and to live the life of a oral physician than just a routine dentist. Now past 6 months I have been working continuously during the COVID times, practicing now also, and I've realized that chronic orofacial pain in combination, like sir pointed out, with psychosomatic issues have increased tremendously, and it is required not to treat them but to manage the case. If we understand the physiology, the anatomy, and the overall psychosocial behavior of the patient, it becomes very easy to support the patient and support the patient in managing his or her chronic pain. Because acute pain, fine, is protective in nature, but chronic pain by itself is a disorder. So I thank Dr. Thomas for this opportunity, and I thank Swapnil and the team of World Dental Association, and I thank all the my co-fellowship batchmates who are watching. Thank you so much for being here. Thank you, Dr. D.
Beautifully, you're welcome. Beautifully done, Kartik. Really nice job. I'm proud of you.
Thank you, sir.
Swapnil, I forgot to share the last slide. It just shows I'm not sure if I'm sharing it now. Just one slide was there.
No, sir. Yeah.
Okay,
Share
let me
screen
just.
is off, sir. You need to share again. Yes, sir.
Okay, no problem. Let me just see if it can be shared. And it just shows the audience what the flow of a course that I'm starting in November is. This is the one that Kartik is. Can you see the screen, Swapnil?
Yes, I'll just add it to the screen.
No problem. So this is the slide that was behind the thank you slide, which I did not realize. I apologize. All it does is splits what the course that Karthik is taking. It splits into these type of succinct days, and the 80 hours, first 80 hours is entirely online, distance learning mode. And then there is an online component again, and then there is the on-site component. And we come to the cities. Karthik is in the Mumbai batch, so that will be one site, hopefully, or maybe South India too. So I just want your audience / your members to know that this is starting this November, next month, and it'll continue through March 2021. And it's a long-term commitment. And I urge them to consider this as a science and evidence-based learning. Thank you, though. Thank you for the opportunity.
Yes, sir. Thank you very much, sir.
You're welcome.
I'm sure we had a wonderful lecture and a great insight on pain medicine, orofacial pain, and we got an insight to think beyond the teeth and the diseases that may cause the pain on the teeth. So, Dr. Swapnil, any questions you would like to ask?
Not really, because this is such a vast topic. Everyone is amazed by the knowledge which Davis sir and Karthik sir has shown, and the cases have been very much. Now, just things that come to my mind is we get these cases almost every day on day-to-day basis, and we've been so foolish to treat them the way we saw the other dentists were treating them. So I specifically love the word oral physician, and probably now dentists in our country would look at this terminology of becoming a oral physician, all because of the wonderful words of wisdom by these two people. and my mind is open to so many questions, and probably it's out of the scope of today's session, but definitely we'll have to add this food to our thought and keep going on and studying the articles. And I'd request even Davis sir and Karthik sir to please share those articles on our forum, so that the members get to
Get
read,
benefited.
and slowly they get a knack of into it, because it's ultimately a passion driven science. And once a person reads through these articles and gets the passion, so definitely he should pursue this as a specific career of becoming an oral physician. So Saurabh sir, may I take over to the vote of thanks?
Yes, please.
On behalf of World Dental Association, admin team, moderators, and all our members, I'd like to thank Davis sir and Karthik sir. You've been phenomenal in this past 1.5 hours, and it's really hard to share your experience of 15 years in such a short span of time. But we are obliged that you gave us your valuable time, you shared your valuable experiences, and at least we've been successful in giving a food for thought for many dentists who've been committing this, I could take the permission to say, crime. We are literally doing some criminal treatments on day-to-day basis on our patients, and these poor patients don't even know that what exactly is happening inside. And thankfully we've now got a food for thought, and we'll be pursuing to learn this stuff. And I hope all our members have enjoyed this session. Once again, a very big thank you to Davis sir, Karthik sir, and all our dear members who visited the session today. Thank you so much, and special thanks to Karthik sir for pursuing. He's such a humble person, and I'm thankful that it's all because of Karthik sir we've got the exclusive chance to listen to Davis sir. So thank you so much. Yeah, and it's over to you, Saurabh sir.
Yes, sir. Thank you very much for accepting the invitation on WDA. Davis sir and Karthik sir, you have opened many thought processes for us. Thank you very much, sir. Please.
Thank you, Saurabh, and thank you, Swapnil, and Karthik too. Karthik, you did a very good job. This is amazing. And this is the level that I would love to see my fellowships and my mastership students. They are at the same level, because I think I'm screwing your brains, but this is what it is. This is what you will need, probably. So thank you.
Thank you, Dr. Thomas, for this privilege of even standing next to you on this podium and speaking next to you, sir. Thank you so much. Thank you.
Have a great day, everyone.
Yes, sir.
Thank you.
Take care.
Thank you, Saurabh sir. Bye.
Bye. Take care. Thank you.
Thank you.